So I am presenting the case of Mrs. ABC, a 57-year-old female who is coming from Thrissur, Kerala. She is unemployed. The date of admission was 31st of December 2021 and I examined her on 7th January 2022. Her presenting complaints were generalized weakness and fatigue since 6 months and breathlessness on exertion since 6 months. Coming to the history of present illness, patient who was in her usual health developed generalized weakness and fatigue since 6 months ago. It was insidious in onset and gradually progressive, such that initially she had to take rest intermittently during her routine household chores, and later on, since the last 1.5 months, she is mostly confined to her bed and doesn't do any household chores. She also feels breathless on exertion. It was of insidious onset and gradually progressive. Initially, she felt breathless on strenuous activities and climbing one flight of stairs. Now she is unable to do her routine household works and there is no breathlessness on resting. There is history of loss of appetite and history of loosening of clothes since the last 5 months, which is suggestive of weight loss. No history of black, tarry, sticky stools. She has not noticed any blood in stools. There is no history of hematemesis, no history of abdominal distension. She has not noticed any lump in her abdomen. There is no history of fever, no history of jaundice or history suggestive of itching, no history of cough or hemoptysis, no history of bone pain, no history of headache or seizures. There is no history of chest pain on exertion, no history of suggestive of paroxysmal nocturnal dyspnea and syncope. Coming to the history of past illnesses, there is no history of similar illnesses in the past. There is no history of tuberculosis or contact with a case of tuberculosis. There is history of type 2 diabetes mellitus since 5 years and she is presently on oral anti-diabetic medications. There is systemic hypertension since 5 years and she is on drugs for that. There is no history of dyslipidemia, chronic kidney or liver diseases. She has undergone thyroidectomy 16 years ago and the patient is on tablet Thyronol. She has undergone a cataract surgery in her left eye 7 months ago. History of blood transfusion 3 times in the last 3 months. There is no non-allergies for the patient. Coming to her personal history, sleep is increased and she sleeps during the day also presently. Appetite is reduced, bowel habits are regular, bladder habits are normal, she takes mixed diet, no history of smoking or any other alcohol intake. Coming to her menstrual, marital and obstetric history, menarche attained at 14 years of age. She has had regular cycles of 4 days in a 28-day cycle. No history of dysmenorrhea or menorrhagia. She married at the age of 18 years and that was a non-consanguineous marriage. First child born at when she was 18 years of age and that was a male baby. It was a full-term normal delivery. Second pregnancy, she had twinning. That was at 28 years of age and both those children were male babies. Both fetuses were male babies. Both of them were having full-term normal delivery. Menopause attained at 49 years of age. This is her family tree. Her father had a gastrointestinal malignancy at 47 years of age, but she could not pinpoint what exactly was that malignancy. He also had diabetes, hypertension, and dyslipidemia, and he was on taking treatment for that before he died. Then her mother has diabetes, and her younger brother also has diabetes. Her husband expired because of a coronary artery disease. Her socioeconomic status, 6-membered family, 2 earning members. As per the modified Kupuswamy scale, it is lower middle class. She lives in her own house, water from well and sanitation is adequate. Now coming to the summary of history, a 57-year-old female, a non-case of diabetes and systemic hypertension on oral medication with a past history of thyroid surgery 16 years ago and cataract surgery 7 months ago with a family history of a GI malignancy in her father at the age of 47 years, now presents with generalized weakness and fatigue and breathlessness on exertion since 6 months.
Wonderful. Wonderful history presentation and the way you presented, excellent, extraordinary presentation for an undergraduate. Okay, so you were very confident and the way you presented, not usually some of the examiners doesn't like short forms. So you didn't use any short forms when you're presenting. Okay, and you're very clear when you're presenting. All these things very important to impress an examiner. Okay, in the beginning.
Okay, sir.
So nicely presented. So looking at the chief complaints, generalized weakness and fatigue, and
Fatigue.
exertional breathless for 6 months. What
Yes,
are
sir.
your thought process? When she told like that, what are your thought process in the beginning?
Okay, so this is a 57-year-old female, and my first thought is anemia when she says generalized weakness and fatigue, and I need to evaluate her on the basis of history
Anemia.
on the
Okay,
cause.
good. So at the end of your history, what's your thought process now?
At the end of history, I will be thinking out about a colonic malignancy, sir.
Why? What are the points in favor of colorectal malignancy in history?
Okay, so this is a 57-year-old female who
Okay.
has a family history of a GI malignancy. In her father, and age of father was 47 years of age when he had that malignancy. Then she is presently having the symptoms which are suggestive of a anemia, which is a presenting complaint in colorectal malignancy.
Okay.
And she is having the loss of appetite and loss of weight, significant loss of weight probably,
Okay. So
over 6 months only.
what else can it be?
It can be uh, other than that, malignancy is
It
my
can
first
be
thought.
weight loss is there, loss
Yes,
of appetite is there, anemia
yes,
is there. Okay.
yes.
So what else it can be?
And tuberculosis.
Very good. Anything and everything is tuberculosis in India,
Tuberculosis.
unless and otherwise it's proven. Okay.
Okay.
It's
Yes, sir.
such a disease, Anirudh, I'll tell you.
Uh,
It
uh.
can present like anything and everything. It can mimic anything, any disease,
Oh,
tuberculosis.
okay.
Okay.
Okay, sir.
It's so many atypical manifestations of TB. Okay. So always
Okay.
keep that in mind in any of your diagnosis. First, you have to rule out tuberculosis, especially
Okay, sir.
abdominal. Okay. So good. Let's go to the first slide.
This one.
So, what is the relationship of age with
Age.
respect to, it will stick on to your diagnosis only. Okay, will not
Okay.
deal extensively. So, with respect to your case, you can tell what are the relevance. Okay, so age and your case.
Okay. Age is a risk factor. Elder the age, more is the risk of developing.
So, this colorectal malignancies, as you're telling, history-wise, what is the propensity of getting colorectal malignancy? In which age group it's very common?
It is maximum in more than 80 years of age.
Okay. So it's common after like in sixth decade. Okay, after 60
Yes.
years, it's very common. But like you said, those who are having family history, okay, it could be much earlier.
Earlier.
Okay? So having it could be much earlier. Anything to do with the place?
Based on the diet practices of that place.
Okay, so it can be diet related also. We'll
Yes.
discuss it later. Okay, so
Okay.
next. So only two complaints here are generalized weakness and exertional breathlessness. So more in favor of your, like you said, anemia, or it can be even respiratory, or even the cardiac also. So
Cardiovascular. Yes.
But yeah, we will keep just anemia under evaluation for now. Okay. Yeah,
Okay.
after the entire history. So coming to the colorectal malignancies, what are all the clinical features with which a patient can present to you? Patient can present. Sorry.
Okay. So he can. Okay. So if it is a right colonic malignancy, there is blood loss. So because of which the patient can present with anemia, and the anemia features like exertional breathlessness, exertional syncope, palpitation,
What kind
exertional
of
dyspnea,
anemia?
blood loss anemia, and deficiency anemia.
Very good. Next.
Then it could be features suggestive of obstruction.
Okay.
So patient can have constipation, and it can intermittently recur with diarrhea.
So altered bowel habits, alternate
Bowel habits.
constipation and diarrhea, right?
Yes.
Okay, next.
There can be perforation.
Okay.
And
then so many things. So easy to remember. See, you have to think otherwise. So easy to remember. Remember 5 A's. 5 A's.
Okay.
Okay. First one is abdominal pain or discomfort or mass. First is abdominal pain, or it could be just discomfort in the abdomen, or it could be just palpable mass. Second is anorexia, that is loss of appetite. Okay. Next thing is asthenia. What is asthenia?
I don't know, sir.
What is asthenia? Loss of weight. Patient is cachexic. That's asthenia. Next is anemia. And the fifth one, just like just now you told, altered bowel habits. Easy to remember?
Yes.
If anemia, asthenia, and anorexia holds good for any GI malignancy. Any GI malignancy, if the patient comes to you with anemic, asthenic, and anorexic, first and foremost diagnosis in your mind is any GI malignancy. Along with that, they can have abdominal lump or abdominal mass, and also altered bowel habits. Colonic malignancy. Clear? Now it's easy to remember. Symptoms, fine.
Yes.
So next, so other things can be bleeding per rectum. Bleeding per rectum. What kind of bleeding they'll have?
Fresh bleeding.
Yeah, that's called
hematochezia.
Okay. There is bleeding with stools, with defecation. That is hematochezia. You should know the difference. Just bleeding is rectorrhea. Just bleeding from rectorrhea. Just bleeding. Bleeding with defecation is hematochezia. Hope you know the difference between hematochezia and melena, right?
Yes.
When can upper GI bleed can manifest as hematochezia?
If there is increased bowel motility, or no. We have
usually upper GI bleeding is causes melena, right?
Melena, yes.
Lower GI bleed causes hematochezia. That's what classically we think of. But even upper GI bleeding is very severe. Torrential bleeding is there. There is no time for transit. Okay, then it can manifest as. So think logically. All this logical. Nothing. Big.
Okay, sir.
So that's about. So what other things? Hematochezia. What are the causes for other causes for bleeding per rectum or hematochezia?
Colorectal malignancy. Then angiodysplasias of. Then.
How many are there?
Then anal canal.
Question. Upper GI bleeding and lower GI bleeding can be a question for you in the theory. So I'm just enumerate some 5-10 causes for lower GI bleeding now.
So diverticulosis,
amoebiasis, and IBD.
Inflammatory bowel. Anal canal pathologies.
Anal canal pathologies.
Fissures, hemorrhoids,
and all. Even history is very, very important. You missed some history. Although it's not relevant in this case. I have seen so many patients coming with they're complaining of dark colored stools or having like red colored stools with no problem at all, absolutely fine, but they always complain of this. What could it be? Some just with the diet. So you should always ask with the dietary importance of diet. I'm telling you, even someone eats a lot of beetroot. Beetroot.
Yes.
Red colored stools. That's called beeturia. Yeah. And sometimes nowadays we get dragon fruits. Dragon fruit.
Yes.
Have you heard the dragon fruit?
Yes. Sir.
Yeah, Manu, if someone eats that dragon fruit, then the color of the stool will be red. Blackberries. If you eat blackberries, then the color of the stool will be black. So that's why. So patient will not be having any problem just by eating some fruits or some vegetables. Even then they can complain like this. So history becomes very, very important in this regard. Next slide will go. So here the mainly presenting with you are describing about the anemic symptoms. Next slide.
Negative.
History of loss of appetite. It could be neoplastic or it could be even inflammatory, like
inflammatory causes. Tuberculosis in it.
What is significant weight loss?
That is loss of more than 10% of body weight in 6 months.
Or even the newer guidelines says more than 5% in 3 months. Okay.
Oh, half of that. Okay.
No significant weight loss. Okay. No, why did you ask for all this history? No history of black tarry sticky stools and other negative histories.
To rule out other causes that can cause an anemia or symptoms the patient is presenting with. Like an upper GI bleed can cause melena, black tarry sticky stools. Then blood in stools, if there is high hemorrhage, if she has noticed that, then that will help us in our diagnosis.
Good.
Then hematemesis, upper GI bleed. Abdominal distension is because of the mass or because of any other complications that can arise from the mass, ascites, organomegaly. And lump in the abdomen, if she has noticed that, then our examination, we can have a leading to that. Then fever to rule out tuberculosis.
Okay. Anything else? In
metastatic symptoms.
Malignancy, colonic malignancy, can she have fever?
Yes, sir.
How?
Constitutional symptoms of malignancy.
No. That's tuberculosis, they'll have constitutional symptom, not malignancy. What else? Think. You're a surgeon.
Paraneoplastic syndrome.
Not exactly, but there could be local complications.
Okay.
What are the local complications possible in case of, you already mentioned a few, okay? Like obstruction, what else?
Perforation, peritonitis.
Peritonitis, very good. Abscess. Localized abscess it can form. Then they can have severe fever with chills and all the features of tachycardia and all the features of peritonitis, right?
Okay.
So think broadly. Okay, don't confine yourself to only one diagnosis. Okay, so have at the level of history, have a broad mind. Okay, so next, why did you ask about jaundice and itching?
The primary site of a colorectal malignancy, most common site of visceral metastasis is liver. So to rule out.
Then what kind of jaundice they'll have?
Okay, hepatocellular jaundice.
Okay, then will there be itching?
No, sir. No.
Right?
So, yeah.
Okay, then no history of bone pain.
Bone metastasis.
Any abdominal malignancy is metastasized bone?
Yes.
Okay, where's the first common metastasis to from colorectal?
Liver.
Secondly,
lung.
Okay, these are the two most common. Okay, bone and all maybe very rarely. So headache and seizures.
Brain metastasis.
Very rare. Very rare. Okay, no issue of chest pain and you have to rule out other cardiac.
Other causes of
Fine. So next.
History of past illnesses.
Okay, so you have taken in detail previous anything else is significant here? Any other surgeries? You have mentioned about thyroid. It's not relevant here, right?
Yeah, cholecystectomy is relevant here.
Yeah, very good. Why? Or cholecystectomy? Any other surgeries?
Ileocolic anastomosis.
Any okay. Ileal resections. Special terminal ileums. Very good. Then.
Okay. Then.
I'll give you a clue. What surgery? Patient has bladder cancer. Then what surgery will do? Where will, after removing the bladder, where will they put the ureters into?
Ureterocolic.
Sigmoidostomy. Very good. Ureter will be reimplanted into the sigmoid. So sigmoid mucosa is directly exposed to the urea, which is acidic. So it is acidosis. So that can also cause some cancers. Okay. Colorectal malignancy. So all this previous history of all these surgeries is very important. These cholecystectomy and ileal resection cause increased bile salts. That can again irritant. So that can also cause cancer. Very good. So next. Okay, thyroidectomy and blood transfusion. Very good. No known allergies. Wonderful. Next.
Personal history.
Yeah, increased sleep because of fatigability, reduced appetite. Okay, bowel habits regular, although okay. Colorectal malignancies will have bladder habits normal. Diet, you could have elaborated more on the diet. I felt
Okay.
it
Yeah.
has got more relevance here. So can
Yes.
you could have write mixed diet, predominantly what a non-vegetarian diet or fatty food
Red meat.
or red meat, whatever the she takes. Okay, so can you please tell
Okay.
me, because these are all important, why you think I'm stressing on these things? These are directly for management, it may not have got any relevance or importance, but still why it's important, all these things?
They are risk factors for development of colorectal.
Etiology, we should
Etiology.
find out the etiological factor, right? Just
Yes. Yes.
see, if you treat the hernia, it will recur tomorrow.
Oh, okay.
You should
Okay.
treat the root cause first. What's the root
Ah.
cause for hernia? It could be either bronchitis, chronic cough because of bronchitis, or chronic abdominal pressure, something like that.
Okay.
Without maybe prostatomegaly, something. So without treating that, if you directly do the surgery for the hernia, okay, with the over enthusiasm, tomorrow you will come with recurrence. So always
Yes.
find out the etiology or the root cause and treat it first, and then automatically the your problem will be solved. Clear?
Okay,
So
sir.
diet. So what is the importance of diet in colorectal malignancies?
So the high risk factors for etiology based on the diet will include taking of red meat, decreased uptake of vitamin A, C, E, and other antioxidants. Then it could be the obesity, high lipid content, and
Cholesterol.
fiber content can be protected.
Yeah.
Okay.
So yeah, these are all the diet. Many saturated fat, any saturated fat for that matter. Okay, can you give some example for saturated fats?
Okay,
Any milk products.
okay.
Any animal fat is a saturated
Saturated fat.
fat.
Okay.
Animal fat. In the plant origin, even the coconut oil, palm oil, even Kerala, you use a lot of coconut oil, right?
Yes.
Saturated fat. Even the
Oh.
palm oil. Okay, all these are saturated fats, milk products. Okay, so we have to use very cautiously. Okay, mainly
Okay.
red meat and processed meats, any processed meats, all these, because they don't get digested so easily, so transit time is more. They in contact with the colonic surface, mucosal surface for longer time. That's
Okay.
why these cause all reactions and irritation and may result in carcinoma. Clear?
Yes, sir.
Okay, that's about the diet. What other etiological factors you know?
Uh,
Okay, here we have no history of smoking and alcohol intake. So is it a risk factor?
yes. I have read that it is a risk factor.
Both alcohol and smoking.
Smoking are risk.
We have heard in all the malignancies, both smoking and alcohol causes cancer. Have you ever thought how?
Okay. Probably multiple mechanisms are there.
Yeah.
Nicotine is one, and the other coal tar and other gases that are there, and the
No.
soot.
How smoking or nicotine or tobacco causes cancer? How alcohol consumption causes cancer?
I don't know that exact clearly, sir.
So alcohol, it's it causes there is a impairment of in the DNA. DNA undergoes methylation. Okay, DNA
Okay.
undergoes
Okay.
methylation. That is get impaired while the some toxins present in the alcohol. Also, methionine folate mechanism is there. The DNA that also impaired.
Okay.
Okay, so
Okay.
these toxins present in the alcohol, this cause all impairment of this DNA methylation. So it undergoes some mutation that cause cancer. Even the nicotine or tobacco, it's directly a mutagenic, so which causes mutation. It can mitogenic, that means it causes mitosis, increased mitosis. It's a
Okay.
precancerous. Also, it decreases your immunity, immunosuppressant. Nicotine is a
Oh.
immunosuppressant.
Okay.
So when the immunity is suppressed, you are prone for all the like you don't have any what to say immunity to again fight against the antigens. So that can also
Okay.
lead to the cancer. Clear?
Yes, sir.
Always, whenever your teacher says something, Anirudh, if I say something, okay, you should ask why. You don't directly accept me anything. You're a science student. Okay, you're a doctor.
Okay.
So always ask why for everything.
Okay, sir. Okay, sir.
Think.
Yes.
All these are very logical, most of the things. So next slide.
Okay. Menstrual marital obstetric history.
This is fine, no? So although a
Yes.
little early menopause, that's nothing to got with this our this thing. Okay. So next. This is very nicely put. Most of the UGs don't use this. In fact, even the PGs, I always stress on this particular slide. Okay.
Okay.
Very nicely put. This family pedigree chart should be always be written in any case sheet. It must very nicely depicted. Okay. So okay. So he has a family. She has a family history of father having a GI malignancy.
Yes.
So good. So this is very nicely shown. Everyone must please note, all the students in the case sheet, this pedigree chart should be included. Next. So now go to the English. So what are the other etiological factors for colorectal other than diet?
There can be precursor lesions in the colon.
It could be genetic also. Genetic cause, or with some pre-malignant or precursor lesions like
lesions. Familial adenoma, polyps in the colon.
100%. I'll tell you, FAP. Okay, will 100% lead into colorectal malignancy. So prophylactic proctocolectomy being done in FAP. Okay. Then anything else? FAP. Then
HNPCC.
Lynch syndrome. Lynch syndrome. Then anything else?
Cowden syndrome.
Gardner's. Okay. Then anything else?
Familial adenomatosis poly.
Okay, that's it. And any adenomas, adenoma, carcinoma, that the sequence. Okay.
Sequence.
So broadly, this carcinoma can be hereditary or non-hereditary. Okay. Non-hereditary could be either sporadic or familial.
Familial. Okay. Okay.
Hope you know the difference between what is familial and what is hereditary.
No, sir.
Okay. Familial means many members in the family have the same disease, same cancer. Okay. Some gene mutations they may be carrying. Whereas hereditary means some germline mutation which follow a particular inheritance pattern of inheritance, like autosomal dominant, autosomal recessive. You got it? It's called hereditary. Yes, sporadic means spontaneously. You know it, right? Sporadic.
Yes, sir.
So these are the three ways of inheritance of any cancer. Clear?
Okay, sir.
Next slide. Other than any other risk factor, IBD, we already told. IBD.
Inflammatory bowel.
Okay, ulcerative colitis and Crohn's both have propensity to undergo changes into cancer. Okay. So next slide. Okay. In a patient with colorectal malignancy, has any relation with the socioeconomic status?
Probably diet is influenced by their
socioeconomic. And it's more commonly seen in resource poor countries or lower socioeconomic countries. Okay, so it's more common, and the vice versa also true. Like in our cancer stomach, the upper stomach malignancy is seen in Western countries because of the diet, whereas the lower stomach malignancies are common in lower socioeconomic zones because of the that H. pylori or the some. Okay, got it?
Okay, yes, sir.
So both ways, it's true. So next.
We come to the summary of history.
Okay, fine. So here, never use never use this female, male, and all. I don't like personally.
Okay.
You always should respect the patients. So better to use lady or gentleman. Okay, 50-year-old lady, a known case of diabetes mellitus and systemic hypertension or on regular medications, with a past history of this is may not be so relevant. Okay, if it's relevant, then only include, or is this past history is not required. This is important. With the family history of GI malignancy in her father at the age of 47 years, presents with features of anemia for 6 months for evaluation.
Okay.
Correct?
Yes.
Okay.
Okay, sir.
Yeah. Can I next you'll ask? I'll ask what's your diagnosis at this stage and all. After that, can I proceed for examination? You'll ask. Then yes. Clear? Will the examine? Please, examination part.
Examination. The patient was examined in a well-lit room with consent, ensuring adequate privacy in the presence of a female attender.
The these abdomen 4 points was very, very important. 4 points. Proper lighting, okay, adequate privacy, okay, and informed consent, most important, and in the presence of a female attender. These 4 points should be always followed. Next, adequate exposure. Adequate exposure.
Nipple to mid-thigh.
Okay, fine.
General examination. The patient is conscious, cooperative, and well-oriented in time, place, and person. She is moderately built and nourished. Her height is 137 centimeter. Her weight is 37.9 kilogram, and therefore her BMI came out to be 20.3 kilogram per meter square. On examination, pallor was present, no icterus, no cyanosis, no clubbing, no lymphadenopathy, no edema. Hair and nails were normal. Thyroidectomy scar in the neck, 2 fingertips above the suprasternal notch. Bilateral breast normal. Coming to her vital signs, pulse 78 beats per minute, regular in rhythm, normal volume and character, no vessel wall thickening, no radioradial or radiofemoral delay. All peripheral pulsations were felt equally bilaterally. Her blood pressure was 134/89 millimeters of mercury in the right upper limb recumbent position. Temperature, the patient is febrile. Respiratory rate 20 per minute, regular in rhythm, and that was of thoraco-abdominal in type. Coming
so we'll go back. We'll stop. These are go back. Some small changes to be done. Okay.
Okay.
It's not general examination. It's physical examination. In that comes the, I don't know, what the pattern followed in your college. Maybe this may be right. So usually it is in any books you can check. It's physical examination under which there is a general survey or head to toe examination. Okay, there's a general examination. Okay, physical examination, conscious, cooperative, well-oriented. What is moderately built and nourished? What is
built? Is the skeletal framework, and the nourishment is what we assess by the height, the weight, and the BMI. So I don't know the standard.
So built is for that age, gender, and ethnicity. Okay.
Okay.
Compare with for that age, gender, and ethnicity, then you will tell it's a tall build or average build or dwarf or four-limbed. Okay, that is built skeletal framework. Nourishment is according to the BMI, well nourished, okay, or poorly nourished.
Poorly nourished.
Okay, so now she is in the borderline. Okay, 20.3 good nourishment only. Okay, so but even then we use this having this practice of using moderately for everyone, moderately nourished and moderately nourished. But you should know what is the basis of it. Will not be subjective. If you tell moderately for other, he may look perfectly all right. So you should have some objective assessment to tell anything. Okay, so better to use some objective scoring or before commenting anything. Clear? For your level, UG level, it's perfectly all right. But then there is always a scope for improvement. Okay.
Okay, sir.
Tailor is present. Icterus?
Yes. The liver can be involved, and because of that, icterus could be there.
Okay. Clubbing, cyanosis, lymphadenopathy?
Inguinal lymphadenopathy could be there. That is what we can palpate. So,
edema?
If it is a pelvic organ malignancy, then
even here colorectal malignancy with the liver metastasis.
Okay. That can impair the function of liver, hypoproteinemia, and edema.
Simple. Okay.
Oh, okay.
Okay. Next. Okay. Here. Okay. Also, don't use this. Usually, no radioradial and no radiofemoral delay. Okay. Where do you get that radioradial and radiofemoral delay?
Like if there is a coarctation of aorta, then
only one condition. Only one condition is there where you get this. So it's all a pro forma. In pro forma, they will give everything. Okay, just to okay, but when you write, only write those relevant things which are applicable here in this case. Okay, no need to include everything in every cases. Clear?
Okay, sir.
For example, heart thyroid swelling is there. Do you do trans-elimination test for that?
No.
Huh?
No.
Do you do? Because no, trans-elimination test is a part of swelling, right?
Swelling. Yes.
Do you do?
No.
Why?
We require cystic swelling to do translumination.
Only that part we don't usually read. We miss out that part. Clause that it's only done for cystic swellings.
Swellings.
Okay, so like that, there are some applications of knowledge. Okay, we have to follow.
Okay.
Like that. Next.
Blood pressure, temperature.
Okay, don't write temperature. If you write the measured temperature. Temperature cannot be afebrile, right? Can temperature be febrile or afebrile? No.
No.
Temperature, right? 97 point whatever Fahrenheit or degree, whatever it is, you write. So just write patient is afebrile. That's enough. Okay.
Okay.
So it's better to measure and write. Afebrile, that's again subjective. Febrile, afebrile is subjective. Okay. So better to measure and write for UGs. And okay, next respiratory rate is fine. Next. Okay, please present the abdominal examination findings.
Okay, abdominal examination. On inspection, the abdomen is flat, the umbilicus is central and inverted. All quadrants move equally with respiration. No generalized or localized fullness in any quadrant on inspection. The skin over the abdomen is normal. No scars, dilated veins or sinuses. The external genitalia and back is normal. Hernial orifices normal. Okay, sir. May I proceed?
Yeah.
Okay. Coming to palpation of abdomen, there is no local rise in temperature or tenderness over the abdomen. A single 6 into 6 centimeter ovoid lump in the right lumbar region extending vertically from 5 centimeter below the costal margin in the midclavicular line to 2 centimeter above anterior superior iliac spine. It extends horizontally 5 centimeter lateral to the umbilicus to 7 centimeter lateral to the umbilicus. It has a well-defined irregular borders and irregular surface. It is hard in consistency, but it does not move with respiration. It is immovable on palpation, and it is not bimanually palpable nor bellotable. It becomes less prominent when the patient raises the lower limbs. The rest of the abdomen is soft, no organomegaly, genitals and hernial orifices and back normal, no renal angle tenderness. On percussion, I could feel a dull note over the lung. There were no signs of free fluid in the abdomen. The upper border of liver was percussed in the right fifth intercostal space in the midclavicular line. The liver span was 14 centimeters. The liver dullness is not continuous with that of the mass. On auscultation, normal bowel sound heard over the abdomen. Examination of inguinal lymph node, no palpable lymph nodes. Per rectal examination not done, no neurovascular deficit in the lower limbs. Examination of other systems. Cardiovascular system, the first and second heart sounds were normal, no heart sound, no added sounds, no murmur. The respiratory system, chest clear, bilateral, normal, vesicular breath sounds, no adventitious sounds. Central nervous system, higher mental functions were normal, no focal neurological deficits.
Very good. Okay, we'll go back. So one thing what you missed in the physical examination or general survey is in any, although it's not so important for undergraduates, some examiners may be asking about that. That is, any cancer case or any oncology case, you should mention about what's called performance score or performance status. Have you learned about that?
No, sir.
No, at least do you know any names of scoring?
Karnowski score is there. That name I have.
At least you should mention the names at least, which are the performance scores. Okay, that's used for the treatment. Depending on the scores, we decide the treatment. Okay, whether the suitability for the chemotherapy and all. Okay, so there is something called Karnowski scoring system or performance status. The other one which is used is ECOG. ECOG, European Community for ECOG, oncological, what is it? ECOG group, or oncological something, ECOG scoring system. Okay, these are the two performance status we use, and okay, that's one thing you can include to make your presentation better. Okay, and second, coming to the abdominal examination, how do you say abdomen is flat? I say abdomen is distended.
Okay.
Or examiner may say, no, your abdomen is, the patient abdomen is scaphoid. How do you ascertain yourself, or how do you substantiate? Any objective way, you know, because it's important in all the abdomen cases.
I don't know. Correct.
Ruler. Use a ruler or scale.
Okay.
Keep it over the abdomen on the two ends touching the two bony prominences, one over the xiphisternum, second other over the
pubic symphysis. Okay.
So if the entire abdomen is touching the scale, then it is flat abdomen.
Okay.
If the only ends are touching, but not the mid part, then it is scaphoid.
Scaphoid. Okay.
If mid part is touching but not the end, it means it's distended. Okay.
Okay.
Okay. Then that's all fine. Which swelling is more prominent on inspection than palpation? Which abdominal mass?
Gallbladder.
Yeah, you're right in a way. Movement is more prominent with the inspection than palpation. Anything with the colon? Cecum. Cecum. Okay. It could be more prominent in inspection because of so much distension.
Okay.
Clear?
Okay.
Next. What is Paniol sign, by the way?
That is the shifting of the umbilicus with respect to the position of the mass that can push it.
Okay. If the lower abdominal mass is present, pelvic mass is there, umbilicus shift upwards.
Upwards.
Okay. What is Carnet's test? You have done here, Carnet's test?
No, sir.
Okay. What's Carnet's test?
I forgot.
No, you mentioned somewhere. It's a retroperitoneal mass something, no?
So to ascertain the position of the mass.
Plane of the mass. Okay.
Plane of the mass. Okay.
Plane of the mass. Leg raising or head raising test you do.
Other name for
abdominal
that.
mass, you do head raising test. For lower abdominal mass, you do leg raising test.
Leg raising test.
On contraction of the muscle, if the swelling becomes more prominent, then it is a parietal swelling. If it remains the same, then muscular plane. If it becomes less prominent, then it is a intra-abdominal mass. Okay. Intra-abdominal mass. And again, in intra-abdominal, it could be either intraperitoneal or
retroperitoneal.
Theoretically or historically, they used to examine by knee-elbow position, putting the patient on knee-elbow position.
Okay.
When the patient is put on knee-elbow position, if the mass falls forward and becomes more prominent, then it is intraperitoneal. If it doesn't, then it is a retroperitoneal. Is it clear?
Yes, sir.
Clear? No?
Yes, sir.
Or should I explain again?
No, I got it, sir.
Yeah. Okay. So very good. Most of the UGs miss this part. Abdomen is not just the abdomen, the 8 regions, but also you should check the external genitalia and the hernial orifices and also the back. Very, very important. I can tell you 100 examples to signify the importance of it. Okay, very important. That you mentioned everything. Nice. Next.
Okay, sir. Palpation.
But see, what is 6 into 6 centimeters? See, all these small grammatical errors, or we don't say in the beginning chief complaints. Okay, we don't say since 6 months. It's for 6 months. Okay.
4, 6.
Breathlessness for 6 months. Since means we use for since Monday, last Monday, or since when you exactly pinpoint the date on time, then we use since. All those are small things, but some examiners may make a big fuss out of it. Here also see 6 into 6 centimeter means it cannot be ovoid, right?
Circular. Okay.
Okay. Yeah.
No, it cannot be ovoid.
Yeah. Okay. Although I don't mind all those things, but Okay, you have done very well. You have done very well, but some perfection needed. Okay.
Okay.
It's not. It's ovoid lump in the right lumbar region, extending vertically. All is nice and well defined. What do you mean by well defined?
All the borders could be felt clearly
the
on
entire for entire margin or the border is felt, then it's well defined. If the or ill defined, if the only like pseudocyst, only the lower margin border is felt, then it's ill defined. Okay, the well defined border could be either regular or irregular.
Okay.
Correct.
Yes.
Okay, so it is irregular now, not got a proper shape, or what to say, one proper. It's not equal on all the sides, so it's written irregular borders. Okay, and irregular surface, uneven surface. It could be nodular. Okay, surface. So hard in consistency. Do you for a right lumbar or right iliac fossa mass? Which mass you expect it to move with respiration?
It's a mistake
that masses move with respiration. In general, the mass or the
connected to the diaphragm or structures connected to the diaphragm.
Yeah. So this is far away from the diaphragm or any structure. So no need to. Although classically it's told that any ascending or descending colon masses doesn't move with respiration, but it's not really required here because nothing to do. Okay. You can use the next word. What you used in the next slide? It is
immovable.
Or usually this ascending descending colon mass, especially ascending colonic masses, can be little have a mobility. Okay, mobility, but if it is a fixed, it could be even immovable on palpation. Okay, that's fine. Okay. So what is this? Not bimanually palpable or ballotable?
So from our idea that it is immobile on palpation, I'm thinking of a retroperitoneal structure. So there I have kidney also. So I have to rule out kidney or adrenal mass. For that, I will check the bimanual palpability or ballotability. So I have to keep both hands. The left hand goes under the abdomen. The right hand is kept above. And then I will try palpating with both hands. And then I will try pushing with one hand and I will feel with the other hand. Then this movement is ballotability.
You are not proven that your mass is retroperitoneal, do you?
It is immobile on palpation. It is not a parietal structure.
Need not be.
Oh, okay.
Not be. Okay, need not be. Okay, I told you, if it's fixed with adjacent structure, adjacent organs, or it is very hard. Sometimes it cannot be even moved easily. Okay.
Oh, okay.
So that's not like sure shot to say it's a retroperitoneal or intraperitoneal. Clear?
Okay, sir.
Okay. You see your written becomes less prominent on raising the lower limbs. That only shows that it is a intra-abdominal. Okay.
Intra-abdominal.
Next. Okay. Everything is fine. Okay. Soft, no organomegaly. How to look for organomegaly and all you should know. As UGs, you should be able to demonstrate hepatomegaly, splenomegaly. Okay. All those things. And again, palpation of genitals. How to look for the stricture urethra. How to examine for hernia. All those things you should know. Mainly in the back, what you look for? Renal angle tenderness. And spinal tenderness. Okay. Percussion. Dull note over the lump. How can it be dull over the lump? Dull note over the mass. When do you get a dull note?
Dull note if some structure is filling. So
there is a solid or it's a fluid, liquid, you'll get a dull note, right?
Yes.
So what kind of mass you're expecting here?
A solid mass.
Sorry?
Solid.
Where it is? It's extraluminal, intraluminal.
Okay. So it is intraluminal.
So you'll get two mediums are there. Okay, it's either fluid with the gas with the solid, something like so. In such cases, you'll get impaired note. Okay, impaired note. Even for retroperitoneal, you can still say resonant. If the you are suspecting a retroperitoneal mass, like some sarcoma or retroperitoneal aneurysm or a lymph node, such mass, if you're suspecting, you can write the note is resonant. Why? Tell me.
Because of the bowel loops
Yeah.
overlying.
Clear?
Yes, sir. Yes.
Okay, good. So no signs of free fluid. Okay. Upper border of liver percussion, right fifth. Okay. Liver span is 14. Okay, normal. Okay, good. Liver dullness not continuous with the mass. Very good. Next. Okay. So examination of inguinal lymph nodes you have done. What about any other lymph nodes particularly you want to look for?
Vircho's lymph node. I mean the supraclavicular.
Have you?
I did not mention it, sir.
Left supraclavicular lymph node. Okay. Why it is enlarged? Everything you should study all this theory. Okay. So that you don't miss. These are all the signs of distant metastasis. So now we'll discuss how does this colonic malignancy spread.
Oh, okay.
What are the roots of metastasis?
So the roots of metastasis will include the direct invasion.
Very good.
Then
to the nearby structures like ascending colon. What is there?
Ureter, gonadal vessels.
If it is invades into the ureter, what will happen? What are the local complications possible?
There will be reduced urine output and
hydronephrosis. Hydronephrosis. Okay, next it can invade into
gonadal vessels.
Okay, gonadal vessels. Then
duodenum.
Duodenum, very good. Next.
Then
what muscle is there behind?
That psoas.
Psoas muscle, very good.
Muscle.
Okay.
Then
even
abdominal wall.
Okay.
Sir.
Even anterior also it can spread.
Oh, okay.
Peritoneum. Okay.
Okay, sir.
So next, what other way?
Bloodstream. Most commonly it is lymphatic. Maximally it is lymphatic.
So what is the lymphatic supply?
Lymphatic supply is along the vessels.
Along the blood supply. So what are the blood supply now? Very, very important. Colonic blood supply.
Okay, so the blood supply, this colon is actually having two parts, that is derived from the midgut and hindgut. So it is supplied by the artery of the midgut, superior mesenteric artery, and the artery of hindgut, that is inferior mesenteric artery. So they are arising from the abdominal aorta. They are the visceral branches of abdominal aorta, and the superior mesenteric artery will be dividing in, giving branches like the ileocolic artery, the first branch for the colon, which will supply the terminal ileum and the cecal area. It will divide into ascending and descending branches. From the descending branch, the appendicular artery comes and the anterior and posterior cecal artery. Then right colic and middle colic is also given by superior mesenteric. Now, inferior mesenteric will be giving the left colic artery, then sigmoidal arteries, and it will continue down as the superior rectal artery.
Very good. Wonderful. Blood supply is very important. You know why?
For surgery, it is very, very important.
Surgery. Okay. So remember this point. I'll ask you again later. Okay.
Okay, sir.
One thing what you missed is the supraclavicular lymph node. Okay. Then very good. I really give you 10 out of 10 for this point at least. For rectal examination. Most of the undergraduates miss this. Since you don't do this, not allowed to do this, but that doesn't mean that you should not mention it. Always in any abdominal case, mention about perrectal and pervaginal examination, and you can write not in Bailey. I don't know, in recent previous when we read, it was written, one sentence was there: a candidate can be failed for not doing perrectal examination in a abdominal case.
Okay.
Exact sentence in Bailey.
Okay, sir.
So that's the importance of perrectal examination. Okay. So good that you mentioned that. So no neurovascular deficits in the lower limb because of the compression. Next. Okay. Blood systems are normal. Okay.
Summary.
Coming to summary. Yeah, you are telling about the spread. One is direct spread. What is lymphatic spread? Okay.
Hematogenous spread.
Hematogenous spread. And even the visceral, like transcelomic spread also. Okay. So, okay. On summary, one examination.
On examination, pallor was present. Single 6x6, I should say, intra-abdominal spherical lump in the right lumbar region with irregular borders and irregular surface and a hard consistency, which was not bimanually palpable or bellotable.
So, what's your provisional diagnosis?
So my provisional diagnosis will be a right lumbar mass arising from probably the ascending colon, probably of malignant etiology with diabetes and systemic hypertension.
Wonderful. This is the way to write a diagnosis. Okay. It won't directly conclude. Okay, it's what is colonic cancer, nothing like that. Okay, this is the way. The clinically, you can just conclude this much. What is the anatomical structure? Okay, and is the what is the probable etiology? Or next, if it's malignant, if it is any signs of evidence of metastasis is there, then you can mention with the feature suggestive of distant metastasis or some complications with the complications of obstruction or perforation or abscess, or that you can write. Okay, very good. This is the way to write. Okay, with the you also mentioned the comorbidities for the sake of managed treatment. Okay.
Okay.
Even in some cases like breast and all, you can also include the in the diagnosis. You can also include the age and the post premenopausal or postmenopausal state also. So that's important for the again for the 58-year-old, because the treatment everything changes according to the age and this thing. So 58-year-old for postmenopausal lady having a lump in the right breast. Okay, like that. Clear?
Yes, sir.
So how will you manage your case now?
Okay, so once I have this provisional diagnosis, I will do an ultrasound examination on this on this patient, because that is an extended clinical examination.
Very good. Now I want to confirm my diagnosis. Very good. That's the way. Good.
Okay. So from there I will get where is this lump arising from? What is the type of the lump? It can differentiate between a solid lump and a liquid or solid mass. And then I will be able to see, is there any ascites or is there any hepatic metastasis? So based on that, I will evaluate the patient on the basis of ultrasound. Then I will take all her routine blood investigations. So I can rule out some other infective pathology or inflammatory pathology based on that. And that is required for the management also. Then I will do the investigational choice, that is colonoscopy. So by colonoscopy, I will be able to evaluate where is this lump coming from, what is the site of the lump. Now, and also I can rule out any synchronous malignancy. And
what is synchronous and metachronous? Very good.
Okay, synchronous malignancy means a second malignancy arising within 6 months of the first malignancy. Metachronous after more than 6 months.
No, they both are found on the same time. Okay, different sites. The different site, the malignancy is found in different sites at same time. That is, yeah, you mean right definition wise within 6 months you can tell, but when you diagnose, it will be almost both will be there.
Same, yes.
Same time. If it's at a different time, that maybe after the treatment of the first malignancy, if you find it in the second lesion somewhere else, that is metachronous.
Metachronous. Okay.
After 6 months of the diagnosis, it is metachronous lesion. Okay, synchronous or metachronous lesion. Okay, this is the advantage of finding other lesions also. That is with the colonoscopy. Okay, what's the other advantage?
Other lesions can be like if there is inflammatory. Then
that,
the
diagnostic part.
Other than diagnostic part.
Yeah. Any therapeutic?
I can take biopsy from the lesion.
The same time, same setting, you can take the biopsy also.
Biopsy.
That's the advantage of colonoscopy. Okay. Anything else? Any other? What's the disadvantage?
Disadvantage is that it requires skill. The patient.
It's invasive. Okay. So what non-invasive method you have?
CT colonoscopy.
Virtual colonoscopy or CT colonography. Okay. Even a very small nodule, less than 0.5 mm also you can pick with this CT colonography. Okay. But the only disadvantage is you can't do
biopsy.
Okay. That's but it requires bowel preparation and all. Okay. One day that requires extensive bowel preparation and all. Okay. So even for a colonoscopy for that matter, both requires proper bowel preparation to pick out the small lesions also. Okay, what
Okay.
other investigation you want to do?
Then endoscopic ultrasound will help to
Okay,
stage.
okay, okay.
And a CT scan, spiral CT involving thorax and abdomen. So I can see the metastasis and I
Lymph
can
node
evaluate.
metastasis. Yeah.
So that will be my investigation to stage the disease.
Okay. So anything else? Any blood test or any other test?
Tumor markers.
Yeah, very good. What
So
tumor marker?
carcinoembryonic antigen.
Okay, CEA. Okay. So what's the normal value?
2.5 nanogram per ml.
Wonderful, wonderful. So more than 5 nanogram is
Is significant.
diagnostic.
Yes.
Okay.
Diagnostic.
More
Okay.
than 7.5 is poor prognosis.
Poor prognosis.
Correct?
Yes.
Any other investigations of historical
Then
importance? Barium.
barium enema. Barium enema.
Double contrast barium enema. Okay.
Okay. Yes.
One is radiolabeled dye, another is air. So two contrast mediums are there. Okay. 1 liter of barium sulfate enema is injected. Okay. Then it will be removed. You take the X-ray, and once you remove, then air is inflated. Okay. Then you again take the X-rays. Okay. That's how you do double contrast barium enema.
Barium enema.
And other than one more very non-specific test you do is FOBT.
Fecal occult blood test. Okay.
No, it's not very sensitive, but still that's of importance. Okay, you should mention fecal occult blood test.
Screening it is written.
Screening test. It's used for screening test. Okay.
Screening.
So CEA, is it? What is the value of CEA?
Like sensitivity and specific. Like not specific, but it is sensitive.
Okay. So why it's not very specific?
Because it can enlarge in pancreatic malignancy, and this one also, and certain ovarian malignancies also.
Why CEA? What is carcinoembryonic antigen?
Tumor
secreted in the mucosa of the colon. Okay.
Oh, okay.
They mainly they go to the liver and they get degenerated there by the Kupffer cells. Kupffer cells. Then there is some obstructive jaundice or some cholestasis is there. These cannot reach the liver, so the blood levels will increase.
Yes.
Got my point? Okay.
Yeah.
So in case of hepatitis or pancreatitis or any obstructive jaundice and so many other, like in BPH and so many things in conditions, it can be elevated, falsely elevated. Okay? Very specific. See, this has got prognostic as well as predictive marker. Hope you know what is the difference between prognostic marker and predictive marker.
Prognosis to know how much the patient can benefit and lead a normal life.
Yeah. No. What is the natural history or natural course of the disease before the treatment? Stage 4 cancer means it's poor prognosis.
Poor prognosis. Yes.
It's a prognostic. This thing. But it's predictive is he's stage 2. If I give this chemotherapy, if I give this it's ERPR positive. If I give this hormonal therapy, the patient will get benefited. That is the predictive factor. Got my point?
Yes, sir.
Okay.
Yes.
CEA has got both prognostic and predictive value. Okay. Now the final diagnosis after all the colonoscopic biopsy and all. Now it comes out to be ascending colon malignancy. Okay, with no distant metastasis. Only what is pericolic lymph nodes are involved. Okay.
Pericolic lymph nodes are involved.
Yeah. Okay. What are the stages of lymph nodes? N1, N2, N3?
Like first group of lymph nodes are epicolic lymph nodes, which are lying over the colon.
The wall of the colon.
Then pericolic lymph nodes are there, which are lying on the artery, that is marginal artery of Drummond and that area. Then then proximal to that we have the intermediate lymph nodes
and principal.
Apical or principal.
What is arc of Riolan? Since you mentioned artery of Drummond.
So from middle colic artery to the left colic artery, there is a connection.
It is superior mesenteric artery and inferior mesenteric artery.
Inferior mesenteric artery.
Okay, it's a
Okay.
anastomosis. Okay,
Okay.
that's called arc of
Got Ryola.
Ryola. Okay, so that's it. So okay, now no, without only lymph nodes are involved. So how do you treat this case?
Okay, so for this, the surgery primary modality will be surgery,
Very good.
and the surgery that I will be preferring is a right hemicolectomy.
Okay, why?
Okay, so we have to take the entire colon because we have to remove the lymph nodes, and these lymph nodes are sitting on the vessels, and the vessel supply is in such a way that we cannot remove a part of it just like we do on stomach.
Very
So
good.
the entire area of superior mesenteric artery will have to be removed so that we can take the lymph nodes.
And just 5 centimeter margins are not sufficient. Just as per the blood supply, we have to remove. Okay.
Yes.
So okay, how do you do that hemicolectomy?
We open the abdomen, the vertical incision. So
Okay. After that, what is
then
white line of Todd's?
like a transverse colon and descending colon junction.
No. As in peritoneal reflection over the and the lateral wall of the abdomen and the colon, the anterior peritoneal reflection between the parietal peritoneum and the visceral peritoneum. There is a reflection of the peritoneum. Okay.
Okay.
Over the anterior, ascending colon, descending colon. It's called white line of Todd's. Okay. You will incise and you will all over, then mobilize the entire colon, ascending colon, and the flexures also. Why you need to mobilize the flexures also? The hepatic flexure you need to mobilize. Why? To make it like easily for the anastomosis. There is no tension, so I only gave you the clue also. Okay, there was next part of the question. So from what are the organs you remove in right hemicolectomy?
Terminal ileum is the first thing.
Same blood supply. That's what that's important. Okay.
Yeah, ileocolic artery is supplying ileum and cecum. So then
terminal ileum,
cecum, appendix, ascending colon, hepatic flexure, then up to the 2/3.
1/3. Right.
1/3 of
1/3. For extended, you can do up to the 2/3. Okay, or middle or 2/3. For just straight hemicolectomy, proximal 1/3 is enough. Okay.
Okay. And lymph node also we remove.
Along the involved lymph nodes, you will remove. Okay. Then after that.
Then I don't know, sir.
Just now I gave you the clue. So soon you forgot. Huh? You will leave it. You will cut the ileum and you will colon and leave it like that. Huh?
No, we take the lymph nodes also. Then we make sure that the margins of that resected area is having sufficient blood supply.
Okay. Then
that we check for
the second part of the surgery. You're missing. I told you no. Now you cut the two parts.
Okay. Anastomosis. Ileocolic anastomosis.
Yeah.
Oh, yes.
Iliotransverse anastomosis to be done.
Anastomosis. Yes.
Done. Okay. Half done.
Okay.
Yes, it will be. Similarly, for what's left, the question will be what is left hemicolectomy, what is extended hemicolectomy, and all that you should know. And what is some two questions extra? If you answer everything like this, some extra questions they can ask you. What is no touch technique of Turnbull?
So there, I have heard of that in one of my classes. So what I know is that here we actually ligate the artery, take the lymph nodes, and then only we touch the tumor.
Where you ligate, that's important.
High ligation.
High ligation of superior mesenteric artery from the origin. Why? Because
so that the entire area can be.
That is one. Second thing is when you handle the tumor, they get displaced, and in the artery they can get metastasized in blood. So they will ligate the artery first, then only handle the tumor.
Okay.
So this is nowadays it's not followed, but you should know. Okay, you should know this. Next, what is the aim of any oncological surgery is R0 resection.
Okay.
You know what is R0, R1, R2 resection?
Yes, sir. That is an oncologic terminology which says that after the surgery, if there is no microscopic margins positive, then it is R0. If microscopic is positive, but macroscopically it is positive, but
you're right. Microscopically positive,
macroscopically, but macroscopically, yes. R1.
Macroscopically positive, then it is R2.
R2. R3 is distant metastasis.
Sorry, there is no
R3. Oh, okay.
Okay. Okay. After this, surgery you are done and anastomosis you are done. Okay. Then yeah, and pre-operative stabilization also very important. Okay, and
ERAS protocol, that one. Enhanced recovery after surgery protocol.
Yeah, for ERAS, this is also very important. Pre-operative optimization of the patient with the blood, nutrition, albumin, whatever the low, no, all you have to optimize the patient before the surgery for early recovery. Okay, that's it. And what other thing you can do? What other modes of treatment?
I have chemotherapy.
Okay, what are the indication for chemotherapy?
If it is a stage 3 or 4 tumor, then definitely I should be doing a chemotherapy post-operative. Then if it is a stage 2 tumor with a young patient, microscopically positive margin, inadequate lymph node removal.
Three indications. Simply you can say three. One is positive margins.
Okay.
Positive lymph nodes.
Okay.
And poorly differentiated malignancy.
Oh, okay. Signet ring cell.
Yeah, signet cell, poor, yeah. So such a poorly differentiated malignancy with the margin positive or if the nodes are positive, then you go for chemotherapy. What is the regimen you follow?
FOLFOX regimen.
What is
FOL? So we have 5-fluorouracil here, then oxaliplatin and leucovorin.
Okay. Why leucovorin is given? Or leucovorin also called, what is FOL?
Folate.
Folinic acid.
Folinic acid.
FO means 5-fluoro, F is 5-fluorouracil, OX is oxaliplatin. Okay. So why leucovorin is or folinic acid is given to to increase the power of this 5-fluorouracil.
Oh.
Okay. Synergistic action we will have. Oxaliplatin. What other drugs you know? What are the newer drugs?
Yeah, right. Bevacizumab is anti-VEGF.
Anything else? Irinotecan.
Okay.
Very important.
That FOLFIRI regimen.
Yeah. Okay. So these are things. Next, any role of radiotherapy here?
Like most of these tumors are radio resistant.
Okay.
But if it's a recurrence, and then we might think of radiotherapy. Okay.
So why radio resistant?
Why?
They are radio resistant.
Adenocarcinoma. It is.
No, especially not everywhere. Especially in colonic and radio, because hypoxia, decreased oxygen supply. Okay.
Oh, okay.
That's why radio resistant comparatively. Okay. So what are the complications possible?
Here the complication could be life-threatening anemia, high blood loss, then obstructive symptoms. Then obstruction, perforation, peritonitis, septicemia, hemorrhage. So these are the complications.
What is stercoral ulcer?
I don't know, sir.
Stercoral ulcer. It is ischemic ulcer over the cecum because of the distance of the distant colon. If there is a constricting type of mass in the transverse colon, there will be, and the ileocecal wall also patent. So the ascending colon get distended, and there is a pressure over the cecum. So because of this pressure, there is a ischemic necrosis and causes stercoral ulcer. And if it perforates, it's a grave emergency. Okay, you need to do ileostomy. Okay, in some cases, if they present with this like peritonitis, perforation, or abscess and all, you can do 3-step surgery. The first step, you just do the proximal ileostomy or colostomy. In second stage, you do the resection anastomosis after 4 to 6 weeks. Then after 8 weeks, then you do the colostomy closure. Clear?
Yes, sir.
Okay. The 3 stages you can do the surgery. Okay. So complications you are told. Then anything else?
Second look surgery.
Yeah, very good. I wanted to ask you that. After all the treatment, there is a role of second look surgery in colonic surgery. What is that? second look surgery, or what's the name? Wengenstein's second look surgery, I think.
Sir, okay.
What is that?
Actually, I don't know that, sir, but it is again reopening the abdomen to check the adequacy of the procedure we have done.
Okay, after the surgery, after the chemotherapy, you can just do the either laparoscopically or just opening again exploratory laparotomy you can do and check for the adequacy of any residual tumor is there, any peritoneal metastasis is there, anything is there. You can check by opening the abdomen or laparotomy. That's called Owen Wengenstein's second look surgery. Okay.
Okay.
What is HALS? HALS? If you, because I am asking, this is not for you, but since you answered everything, so I'm asking you. Others, so many PGs also attending your session, so for their benefit, I'm asking you. Okay. What is HALS? Hand assisted laparoscopic surgery.
I don't know, sir. Hand.
First time this hemicolectomy, everything can be done. Laparoscopical also, all the dissection, everything nicely you can do. And for the removal of the specimen, you can use hand because specimen is very big. You can just laparoscopy. You need a big, small incision at least. The laparoscopic port incision is not enough. So,
okay.
So hand assisted laparoscopic surgery.
Laparoscopic surgery. So we put the hand inside and take it out.
Yeah.
So the incision should be widened also.
Yeah.
Okay.
But minimum dissection, the patient will not have that wound infections and very big scar, nothing. Okay, only minimal wherever in hand goes, that much is enough.
Oh, okay.
Okay. The only problem with the laparoscopy, you don't have tactile feedback. What the structure feels like, you don't know that. So that may sometimes you may use your hand for that, for the tactile feedback thing. Clear? Wonderful, dear. Do you have any other slides?
Few images I have. So this is a pathological image, which shows ulcerative.
What type of ulcer pathologically? What type of mass they will have? Ascending type?
Ascending type can be ulcerative and cauliflower type. So ulcer proliferative.
Necrosis and bleeding, they will have anemia. Whereas descending colon will have
annular and constricting type.
Tubular.
Annular, tubular.
Okay. Next.
Then investigations one by one. Ultrasound, colonoscopic view, and CT image.
Very good.
Then hemicolectomy types.
Okay. See, right hemicolectomy, extended right hemicolectomy, transverse colectomy, left. Okay. Read about this, okay, in detail. Okay, you have answered everything.
Sir, do we do this transverse colectomy and sigmoid colectomy?
Yeah, that can be done, but preferred one is even for the transverse colon also preferred is extended right hemicolectomy.
Okay.
Even for sigmoid we do the left hemicolectomy.
Left hemicolectomy.
For splenic flexure, some people do left hemicolectomy, some people do right extended hemicolectomy up to the proximal descending colon. That both can be done.
Okay. In Bailey, this extended thing is up to the splenic flexure. So actually, extended right hemicolectomy was written as extending up to the splenic flexure.
Yeah, in some books it's written differently. In some book it's written proximal 1/3. In some books it's mid. That's right hemicolectomy. Okay, just know
I got confused with that.
For the blood supply. Okay. Any other doubts? Any other image? Okay, nice.
This, I think that's the end of it.
See that is where the incision is given. No, see in the first image, can you see that incision line, the laterally? That's over the white line of Tolls.
This one.
That that is the lateral incision. Yeah.
Okay.
Lateral one. So any other? Yeah. What are the structures you should be? You already told on left hemicolectomy. What are the structures you should be careful about when
the left ureter, left gonadal vessel, and the tail of the pancreas.
Sorry.
Left ureter. Am I audible, sir?
Yeah. I'm just
left ureter.
There in the YouTube as well. Okay. Tell me.
Left ureter, left gonadal vessel, and the tail of the pancreas.
Tail of the pancreas. Very good. Okay.
This is the end of the presentation.
Yeah, good, good, very good, wonderful presentation. It was much better even than a PG presentation. You answered almost everything. Everything you answered. See, what happens is because of your such well-prepared presentation, so many thousands of other students get benefited. This class will be watched by so many thousands of students. So since you answered everything, even it will be helpful for them to study better. Okay, that's the advantage. This is the condition wherein you will be learning as well as teaching others simultaneously. Very rare opportunity, no? Whereas learning as well as teaching others for your from your well-prepared presentation. Many of your classmates or batchmates or juniors will be learning from you how to answer, how to present a case, how to write a case sheet, everything. So this ideal case scenario what you have written. Okay, so and from us you'll be learning a little bit more also. So this is both mutual learning as well as teaching session. Okay, so because of your well-prepared presentation, even I could learn a lot. Many others also will learn a lot of things today. Okay, thank you so much for that, Mr. Anirudh. I don't want to waste much of your time because time is precious. Your exams are coming up next week.
Okay. Sir, before winding up, I want to thank you on behalf of all my friends, because we all watch this and we are very big fans of the Vitamin platform. And if the idea is that if we can watch a 2-hour, 2.5-hour session on that, then any question that can come in the exam, we'll be able to face it with confidence. So that is what we all want to say to you, sir.
Yeah, thank you. Glad. Okay, we want to do it in a much better way and very organized way. And yeah, I really appreciate you because you found one case which was missing in the entire out of 800 videos plus videos, and you presented that. Although even though it's very difficult for a UG level, and I really appreciate. Hats off to you, man. And
thank you so much, sir.
Please come up with many more case presentation even after your exams whenever you are free.
Yeah.
Because that may not be for you, but through you, others will be learning better. Okay, it's a wonderful.
I will definitely do that. Definitely do that.
Whichever cases you already taken, okay, so you can just present that. Okay, I'll call the best of the best mentors from the India, the best senior most professors, renowned examiners. Okay, so we can have good discussions with them. Okay, so please encourage your juniors also. Okay, to present many more cases like this. So thank you so much once again, Anirudh, and all our beloved members who constantly support us and motivate us to do more and better always. Thank you so much. And yeah, this Anirudh will send me this PPT, and this will be shared in the Telegram group, White Army Telegram group. This will be available for your future references. Okay. Thank you so much, Anirudh. You're looking like a perfect surgeon. Okay. Looking like
uniform.
Okay. Yeah. Hope you take up surgery in future and become the best possible surgeon. That's our best wishes and prayers for you. Okay. I don't have any words to describe your presentation. One of the best I've seen so far. And so yeah, I just wish and pray that you become the best surgeon and serve the needy people. Thank you so much.
Thank you, sir.
Yeah. Shall we end the session?
Okay, sir. Thank you so much.
All the best for your exams. Do well. Okay, like this.
Exams. Okay, sir.
I want to hear good news from you soon.
Okay, sir.
Good.